All right, well, welcome everyone to the second week of our CAPER Academy. This is the second week in the series of 5. We're really excited today to have our moderators and speakers focused on a pediatric topic. So I am going to turn it over to our moderators to start this session.
All right, thank you, Melina. I'm here. I'm Liush. I'm a professor at the University of Iowa, Pediatric Gastroenterology Division, and together with me, Dr. Chinaya Dike from University of Alabama at Birmingham. So we welcome you. This is a very exciting session on pediatric pancreatology. And we have two very exciting speakers, Dr. Mark Lowe and Dr. Cheryl Garepi. So, and none of them really need any introduction, but I'm going to try it anyway. I'm going to present Dr. Mark Lowe as our first speaker. And this is a very interesting talk about genetic testing. Dr. Lowe is a professor of pediatrics at the University of Washington University School of Medicine in St. Louis. He's interim associate dean for research, vice chancellor, and Harvey Colton Professor of Pediatric Science. So, Mark, please just go ahead and tell us about the pediatric genetics and who should get the genetic testing.
Right, thank you, Olia, and good afternoon to everyone. It's a pleasure to be invited and talk about this very pertinent topic related to care for children who have acute recurrent and chronic pancreatitis. I have a disclosure. I am not a genetic counselor. So this is my take on the genetics of acute recurrent and chronic pancreatitis. So we know from a number of linkage studies that there are genes or genetic variants that are associated with chronic pancreatitis. Some of them are Mendelian, so the PRSS1, or the hereditary pancreatitis, the trypsinogen gene variants are inherited in an autosomal dominant fashion. There's also an autosomal dominant inheritance of a syndrome that includes chronic pancreatitis in the carboxyl lipase gene. But most of the variants are not Mendelian. They're genetic risk variants, which means that they're enriched in affected individuals, and they don't cause disease in isolation. And this means that most of our patients have complex disorders. They're not explained by clinical pathological disorders or Mendelian genetics. They're a combination of factors. They can be environmental stressors. There can be combinations of genetic risk variants or other factors that are involved in patients who develop acute recurrent and chronic pancreatitis. So the main question is who should be considered for genetic testing? And there are several categories of patients that you should consider for testing. Those that have recurrent attacks of acute pancreatitis for which there is no identifiable cause, idiopathic chronic pancreatitis, a family history of recurrent acute pancreatitis or idiopathic chronic pancreatitis in a child who presents with their first episode even, if there are relatives that are known to carry mutations associated with hereditary pancreatitis, such as the PRSS1 mutations, if a patient has you're thinking about a diagnosis of chronic pancreatitis, but imaging studies are not clear, but you have other clinical or biochemical evidence of that. And of course, genetic testing in patients eligible for approved research protocols could certainly be considered. Now, I'm not going to end there because that pretty much answers most of the questions I was asked to answer, but I'm going to expand on these a little bit. So genetic testing. So if we look at kids who have recurrent attacks of kids and adults who have recurrent attacks of acute pancreatitis for which there's no identifiable cause, in childhood, there are more than 50% of those kids will have an identifiable genetic risk variant, and over 20% of adults will have a genetic risk variant. So your pretest probability of finding a genetic variant in these populations is really quite high, much higher than the pretest probability of getting a positive test in almost any other laboratory testing that you do. So this is a population where it makes sense to do genetic testing, either in kids or even in adults who have not had genetic testing already. The other group is kids with chronic pancreatitis. And if we look at the percent of those patients who have a genetic risk variant, in children, it's between 60 and 70%. Adults, it's still around 20%. And if you just look at adults who presented with their first episode of pancreatitis in childhood, almost 80% of them will have a genetic variant. So in these populations, even though they already have chronic pancreatitis, it may be useful to know whether or not they have genetic variants, and you're very likely to find one in these patient populations. So genetic testing, relatives known to carry mutations associated with hereditary pancreatitis. So here's a family tree. This was actually, mother was a patient of mine many, many years ago. And in fact, her diagnosis was made in my lab in those days when you could do that kind of thing. And so she was probably the first person in the St. Louis area who was diagnosed with hereditary pancreatitis. When I came back to St. Louis after my time in Pittsburgh, the family came to see me because they're young. They have two daughters. Their youngest daughter had some other congenital anomalies and was entered in the Undiagnosed Disease Network and evaluated. And as part of that evaluation, they do a whole genome sequencing, and they didn't find an explanation for her syndrome, but they did find that she was a carrier of the R122H gene. At that time, she was a month old. She had an older daughter, 4 years old, who up at that time had no health problems and had not been tested. And the family chose at that time not to test, although this would have been a reasonable candidate for testing. Shortly after that, the patient presented with abdominal pain, elevated lipase and amylase, with a CT scan that showed a large fluid collection adjacent to her pancreas. So this was her first attack of pancreatitis. She went on to have another attack of acute pancreatitis that led to a prolonged hospitalization with multiple fluid collections. And she obviously, after the first episode was tested, she had a R122H, and now she also has disease. Fast forward a few years, the 4-year-old has actually undergone, she's now 8, has undergone total pancreatectomy with auto islet cell transplant, which was pretty much the result of her second episode. The 1-month-old is now 3 to 4, I guess, and so far has not had a documented episode of acute pancreatitis. And there's about a 20% chance that she may not. But this is clearly a family where testing could have been done. And there was a long discussion with the family about whether or not they wanted to test the 4-year-old before she was pre-symptomatic, and they elected to wait and see. Here's another example of a patient who had possible chronic pancreatitis, but things were unclear. So this is a 3-year-old female who had abdominal pain and normal stools. Her growth was normal. Her fecal elastase in multiple tests was less than 15. She had an elevated quantitative fecal fat, and the CFA was only 60% on a 72-hour collection. She had a normal liver transaminases and bilirubin and a normal sweat test. Imaging wasn't particularly helpful. Her abdominal ultrasound and MRCP were done. They showed a mildly dilated common bile duct that was not that impressive. The pancreas itself looked normal. There were no calcifications or other things to suggest chronic disease. Because of this, she had genetic testing done. In this case, we also included testing for the SBDS gene, or the Shwachman-Bodiam-Diamond syndrome gene. And CFTR, SPINK1, PRSS1, and was also included. There were no variants in the SBDS and the CFTR gene, but there was one in the SPINK1 gene, which is the PN34S. Now, we know that patients who carry this particular variant have an increased risk to develop chronic pancreatitis. But the caveat here is that this is a very common variant in the general population, perhaps approaching 2%. Of these carriers, and so most of them do not develop chronic pancreatitis. And this patient clinically has never had an episode of acute pancreatitis that was diagnosed. So this is a case where the genetic testing was suggestive, but not necessarily helpful. And this patient is on pancreatic enzymes, and her stools have improved. She doesn't have abdominal pain anymore, and we're simply following her to see what happens. But this is, if you had found another variant, such as a PRSS1, this would have been helpful in this case. So what type of genetic testing should you do? I think most of you have looked into this, know that you can do, there's still single gene analysis. So you can get a hereditary pancreatitis panel, which is mostly PRSS1. There are multi-gene panels that test the more common genes that have variants that increase risk for chronic pancreatitis. And you're going to have comprehensive genomic testing, such as next generation sequencing, whole exome or whole genome testing. So let's talk a little bit about single gene testing. And I think this is something you should consider if family history clinical findings suggest multiple family members are affected. So for instance, in PRSS1, I already mentioned it's autosomal dominant, although it can skip a generation. And the onset of acute pancreatitis is usually in high childhood. So if you have a history of multiple family members, you may want to just first test for PRSS1. Or if, as in the example I gave you earlier, the parent was already known to have PRSS1, then testing the child makes sense, which is a single. CFTR is another one to consider, is that you'll have a family history of cystic fibrosis, perhaps. Maybe history of sinusitis, nasal polyps, male infertility, indeterminate sweat test would be reasons just to focus on CFTR. Carboxylister lipase, which is a very unusual and uncommon mutation. It can present, particularly in early adulthood, with maturity onset of diabetes of youth. They have often can have unexplained exocrine pancreatic insufficiency. In these patients, pain and recurrent acute pancreatitis are not present or are mild. They certainly don't dominate the clinical pictures with some of these other variants. So in these cases, you may consider just a single gene analysis. And typically one would do a sequence analysis first, then gene targeted deletion and duplication analysis, which is something that many of the labs will automatically do. Of course, multi-gene panels are fairly common. You want to consider these when you have no history to indicate a single gene. The genes included may vary. The graph on the over here shows the percent positive for risk variants in a population of children. So the most common variants are found in PRSS1, CFTR, and SPINK1 gene. These are typically included in virtually every gene panel that's around. Most will also include CPA1 and perhaps CTRC. Typically, the CSR, the calcium sensing receptor, and the TRPV6 gene are not included, although we do find those in kids. So for most kids, you're going to pick, if they have a genetic variant, you're going to find it with a panel that contains these 5 genes. Analysis may differ. There may do sequence. Some places may also do deletion, duplication, which can be important at times. And once in a while, the panel may include genes that are unassociated with pancreatitis, and it may not be necessary to do those. Typically, if you're going to look for a multi-gene panel, you would want one that's going to cover at least the 5 most common. Comprehensive gene testing, which would be exome sequencing or genome sequencing. Either one of these can be done. Oftentimes, this is done as part of a research protocol. And if you do these kind of sequences, the American College of Medical Genetics recommends informed consent, so that genetic counseling with documentation of consent should be done. Discussion of possible significant incidental findings, expected outcomes, including likelihood of incidental findings, potential benefits and risks, and remembering that we don't have a current therapy other than surgical therapies. There's no clear distinction between clinical and research testing, and the future, make sure there is a clear distinction between clinical and research testing. Future use of data, included deposition in a database, should be discussed and quite clear. And also your policies regarding recontact as new knowledge is available. And that will occur. And there are times when you may want to consider retesting. So reanalysis. So if there's new evidence about association of a variant of unknown significance with pancreatitis, or new evidence about effect on function, then it may be time to either reanalyze the genetic testing, or if that variant was already reported in the patient's previous study, to recontact them to talk about it. If significant time has elapsed since the last testing, some of these patients will have had gene testing when there was only a 2 or 3 gene panel. So their broader panels are available. There's also been many improvements in DNA sequencing technology. There's also many advancements in bioinformatics, and we know a lot more about variants these days. And also new risk variants are identified, and they may not have been reported in previous lab tests. So in these cases, one might want to consider retesting, particularly if you don't have an explanation for the patient's acute recurrent or chronic pancreatitis. Additional patient phenotypes or family history become known. And because of the fact that you may want to go back, it may be important to consider banking DNA when you first collect samples from the patient. Thank you, and we will take questions after the next talk.
Thank you, Dr. Lowe, for that wonderful and important talk. And while Dr. Garipi gets up her slides, I'm going to introduce her. I'm honored to introduce our next speaker, who will be also speaking on a very important topic on transition of care of children to adults, children with pancreatitis to adults. Dr. Garipi is a professor of pediatrics at the Ohio State University College of Medicine. She's also the associate director of the Peace GI Fellowship at the same institution. She's the vice chair of the IRB and an editor of our famous journal, JPGN. She has authored a paper on this topic, and she'll be speaking to us about transitioning children who have pancreatitis to adult care. Thank you. Dr. Garipi, you can take it from here.
Okay, can everyone hear me?
Yes, we can.
Okay.
We can't see your slides anymore, but we saw it.
Because I couldn't see if I was muted or not with the slides on. So let me put this back on. Okay. We go to show. All right. Yes. So this topic is a little bit challenging because I have written a paper on this, but it's basically the only paper on this subject, and it's really a call for more investigation and more work in this area. So my objective is to have a call to action as far as the transition of patients from pediatric to adult care. I have a little bit of data about the scope of the problem. I have some thoughts on the unique challenges to the patients with pancreatitis in transitioning and transferring care. I have some thoughts on the inequities that may be involved in this process. So first of all, the definition of transition versus the definition of transfer. So transition is the change from a parent supervised and managed care to an independent patient-centered care. Whereas transfer is the actual change of the provider from the pediatric provider to the adult healthcare system. Now, these terms are often used interchangeably, and I will probably do that as well and refer to the movement of the patient from pediatric care to adult care as transition, although technically you can transition and not transfer care. I have patients that show up by themselves and are pretty much managing things. But it's very challenging if you transfer, but you haven't transitioned. We have a lot of people in pediatric hospitals who have developmental cognitive impairments who cannot transition, and they are particularly hindered in their transfer to the adult healthcare system. And as I said before, transfer without the transition to behaving as an independent agent in taking care of your health often leads to gaps in healthcare and poor outcomes. And that's been demonstrated in many different patient populations: kidney transplants, liver transplants, diabetes, all sorts of different populations have been studied, although there really haven't been any studies related to patients with acute recurrent or chronic pancreatitis. So pediatric subspecialists devote a lot of time and resources to trying to support the transition of care. And that's becoming more kind of standardized in pediatric subspecialty care. So this is the little bit of data that is out there, and this was collected by me at Nationwide Children's and by Maisam Al-Bualhaja at Cincinnati Children's. So we worked together to try to assess the magnitude of the problem at our two institutions. So these are patients that were seen between January of 2014 and December of 2019 with a history of acute recurrent and chronic pancreatitis. And it's color-coded by their age group. So 793 patients in Cincinnati, 656 patients at Nationwide Children's. And a good chunk of those are less than 18 years of age. But you see there's quite a large number that are over 18, and even some that are over 39 years of age. Those are very likely people who are have multiple other medical problems and cognitive impairments that prevent them from really transitioning in their care. Although at my institution, we are taking care of adults with congenital heart disease who are getting heart transplants. So, you know, I see 30 and 40-year-olds sometimes in my clinic related to liver issues. So a big chunk, 30–40%, are adults that are in the children's hospital setting. And then this is kind of spreading out just those patients that are over 18. So you can see that the majority are the 18 to 24 range, but then we do have a smattering of people who are even older. So then with Dr. Al-Bualhaja and with Louis Laura at the Ohio State University Wexner Medical Center, we put together some further data to see where the young adults are being seen in our region. So in the 18 to 23 year range, over on this side, you see there's a big chunk of the young adults that are still being seen at the Children's Hospital, and actually a smaller chunk in the adult healthcare setting. By the time you get over 24, that is reversed, and we have now the majority of them being seen in the adult healthcare setting, but still quite a chunk that are still over in pediatric world. So now if we talk about disease-specific challenges that these patients may face, we have to understand that acute recurrent and chronic pancreatitis is a progressive inflammatory disorder with no known treatment to actually alter the course. The median time of progression from initial attack of acute pancreatitis to chronic pancreatitis is less than 4 years. And within 6 years after the initial attack, 18% of children have exocrine pancreatic insufficiency, and 7.7% will have diabetes. And that was based on analysis of the INSPIRE-2 database. As time goes by with these disorders, there's an increasing burden of secondary disorders. So the exocrine pancreatic insufficiency, of course, is associated with steatorrhea, vitamin deficiencies, sarcopenia, and osteoporosis. And this can be particularly important in the young adult, where this is really their time to build up muscle and bone mass. With the diabetes, of course, you get nephropathy, cardiovascular disease, nerve damage, and a whole host of other secondary disease burdens. One thing that's, I think, really unique to pancreatitis treatment is the social stigma that these patients will report. The association with alcoholism leads to the suspicion and accusations when they present to the adult healthcare system. And because it's an invisible disability that can lead to significant absences from school and work, these young adults really have difficulty in explaining their disability and their absences, and often will not report it to employers or schools. The other challenge is that pain is a central feature of the disorder. So recurrent or chronic pain through adolescence impacts normal development, including emerging autonomy, maturation of peer relations, educational and vocational functioning throughout life. And chronic pain in adolescence predicts a poorer outcome in adulthood across health and socioeconomic measures. There's also a problem with the reliance on opioids for pain control, despite the lack of effective long-term pain control and the association with worse outcomes and mortality. The lack of available comprehensive pain management programs in adults. For our patients at my institution, we have pain management specialists, we have the endocrine doctors, we have, myself, we have surgeons if they're necessary, advanced endoscopists who can coordinate their care, and the patients can be seen by multiple specialists at one location and hopefully a coordinated fashion. Once they move into adulthood, you have to find these programs is very difficult. And they may need to transfer and navigate multiple providers at different settings to kind of replace their pediatric home. So thinking about inequities, I was reading a very recent paper on sickle cell disease and transition. And this was just interviewing the patients. And it really, made me think about, I know my white patients have difficulty in going to adult ERs and being thought of as drug seekers. But people of color may have even more challenges. So these are some of the quotes from that paper, Sickle Cell. It was hard to learn to communicate my needs to white people when I'm in pain. They believe I'm drug seeking because of my race. They thought my pain was worse because I was a girl or couldn't handle it. And then, of course, there's the expense. For young adults, this can be very challenging. 2 to 3 months later, you get a letter from the hospital with a bill for $1,800 that you have to pay out of pocket. It makes me not want to go to the hospital. It makes me not want to seek treatment when I'm in pain. Then I think about the ED experience, and I think this is something that probably is important to my patients, though, like I said, we need to really study this more. So first of all, children, adolescents, and young adults treated in pediatric emergency departments are much less likely to be prescribed opioids compared to patients of similar age and ailment treated in general EDs. The median number of emergency room visits and hospitalizations is similar between pediatric and adult cohorts with ARP and CP. So this was looking at the INSPIRE cohort of children and the NAPS2 cohort for adults. And then I think about the difference in the waiting rooms just in general. The acuity of the crowding, the waiting that goes on in adult emergency rooms, I think likely plays a role in the fact that my patients who are in their 20s keep coming back to the pediatric emergency room. And a few of them have gone across the road here to the adult emergency room and then decide they're not going to do that anymore and come back to pediatrics. So, when they have a choice, they often decide that they're more comfortable. They get probably quicker care coming to the pediatric emergency room. And then I've been having some thoughts about our approach to transition. So at my institution, we're talking a lot about transition and transfer, particularly with our IBD patients. And young adults who are in college are considered to be in a transitional time of life. So we don't expect them to transfer to the adult healthcare system until they are out of college. And that makes some sense. They may move to a different town, they get a different job, but why have them get a new provider for a few years while they're in college and then have to transfer to somebody new? I understand that. But young adults with high school education who may go out and get a job, may get married, may have children, they are considered to be doing adult things, and they are expected to transfer to the adult healthcare system. But what this attitude results in is that the people who are probably are richer resourced, the kids who, the kids who are going to college, they are not expected or asked to do the transfer of care, where they may have less support and less less support in the clinic and in the resources that are available. But young adults who may be even younger, but who are out in the job world and have less resources, they're expected to move along and make it to the adult healthcare system. And I just wonder if that's really a fair thing to ask them to do. They may have more support needs because they are out with a job and less resources than the kids who are in college. So as part of the paper that we've written about transfer of care, we did include, this is the only resource I can provide to you, a pediatric to adult transfer summary document. And this was actually developed by Luis Lara, surveyed adult providers and to find out what kind of information did they really want. One of their complaints with the transfer of care is that we have someone who's had 10, 13, 15 years of ongoing treatment, and then they either get nothing or they get a huge stack of stuff to wade through. So he surveyed adult pancreas providers to develop a summary document, and that's included as the it's in the publication, but as a supplementary material. So if you access the journal article online, you can get that document. I've included a link here because when they put the document as a supplementary material, they did it as a PDF, and no, they did it as a PowerPoint, which is completely, you can't fill it in and it's not useful. So this link here is a link to a fillable form. It's a PDF where you can fill in the items that you would want. So this is the page 1, top of it. It has the fillable form, the contact information, and then it has stuff like, what genes were tested, when were they tested, when was PERT started, have they had a DEXA result, and then something with the pain patterns. It's a total of a 3-page document that includes all the information that, at least on our survey, the adult providers wanted. So again, this is really a call to action. We need to know more about the barriers to transition and transfer in this population. We need to study evidence-based interventions to improve the transition. And we need adult healthcare partners. And I think that's really important too. Like I said, with many conditions, it's been shown that after transfer of care to the adult healthcare providers, there's often gaps and organ loss or worse health outcomes, at least in the initial few years after transfer. And while we can do as much as we can to try to adultify our young adults and get them on board with behaving like adults, they're going to make mistakes and they're going to have struggles. And I think I would have the adult healthcare partners think more about the needs of young adults in their clinics and think about how they can support them a little bit better. So the paper that describes what we think are the challenges for transition of care was written by Luis Lara, Jeff Easler, Aliyah Uch, and Ala Sheikh Alil. And then some of the data that we gathered and that I showed at the beginning, again, was done with Luis. and Maisam Abu al-Haija. And with that, I will end and be happy to take any questions.
All right, thank you, Dr. Garipi and Lo, for the wonderful talks. So please put your questions in the chat and we will try to get to them as much as possible. And I don't know, Chiney, if you have any questions. I thought about a few questions that I can get it started. I see Cheryl's question, so we can start with that. So you recommended testing in ARP with no identified cause. Do you recommend testing in children who have had recurrent pancreatitis with exposure to more than one chemotherapeutic agent? What about children that get recurrent pancreatitis with recurrent episodes of DKA?
So I guess the first thing to talk about is if a patient gets acute pancreatitis on a chemotherapeutic agent that has a known association with causing pancreatitis, you have to have a really good reason to give it to them again. And it does happen. But I think that's a judgment call. I would probably test that patient, even if it's somebody who's been given asparaginase a couple times. Because there is some data that some patients will have pancreatitis in association with asparaginase treatment and then tolerate asparaginase after that. But if you didn't test them, I think that's not a major deficit in their care. And children that get recurrent episodes, pancreatitis recurrent episodes of DKA. Yeah, I actually, that's not that common. So I would test them myself. But once again, there's also some disagreement about the association of DKA with pancreatitis. But my personal bias is that kids who get really sick, it's going to have to be in the ICU or at increased risk to develop pancreatitis. But if it keeps happening over and over again, I would start wondering about other things, and I would do genetic testing along with make sure they don't have gallstones or something else that you can fix.
So I think the follow-up, Cheryl asked, there were two different chemo agents.
Yeah, I'd test them. I think if there's two different chemo agents, I would probably test.
So I can ask a question. So a lot of times parents come to us, if there's a family member with PRSS1 mutation, one affected child perhaps had a TPIAT, and the child, even in the newborn period, is tested, they had the genetic testing and had, PRSS1 gene mutation present, even from the newborn period. So what follow-up do you recommend for those children who have had the positive gene testing for PRSS1 gene, but so far no evidence of pancreatitis? They may be within the 20% or no disease manifestation or 80%. Should we wait until they manifest themselves, or should there be a certain follow-up?
Well, I think it's important to follow them up, and particularly if they have a sibling that already has disease, you're going to follow that sibling. Sometimes they won't, but I still think it's important to follow them up. And whether you want to do that at 6 months or 1 year intervals, I think is reasonable, either one. But what is really important is to make sure the family understands that if the child has symptoms, that they need to contact you so that you can direct them to get laboratory testing. I usually do both lipase and amylase. So I think it's really important to impress on the family that importance. And typically they understand it because one of the parents has had the disease and they're comfortable with that. But I think still, they're still at risk, and then they can present at pretty much any age. And I think following them at a regular interval helps to support the idea that this child does have a genetic variant that can make them sick and cause disease, and that we need to be mindful of that and keep on top of it.
Thank you. I'm going to ask Dr. Gary P. one question to give Dr. Lowe a break before we take the other two questions. Dr. Gary P., what a wonderful talk, and very important at that. And thank you for looking at that and publishing the first paper on that topic. How do you see transition of care with adult and pediatric providers in the same room versus just a document that is just a warm, handoff? Which one is more effective, and are there institutions that are able to bring adult and pediatric? Are there institutions and subspecialties that are able to bring adult and pediatric providers in one room, which actually gets the patient who is being transitioned more comfortable with adult care before they actually move to the adult providers?
Yeah, so I think that that's generally been considered the best approach. Although people have found that it's extremely difficult to implement, to have the two providers, particularly that get the adult providers, to be available for these types of clinics where they can meet with the pediatric provider and the patient at the same time. So I think most places have found it kind of unworkable, desired, but unworkable. What I did with Dr. Lara at OSU is actually, he would come join the meeting, join our thing by video. So I would sit in the room with the patient and he would kind of video in. And that way there was no traveling across town for either one of us or something like that. And he could video in, we could sit in a room in my clinic and have a discussion with him and the parents and the patient. And I think that works pretty well. Although even that, it's difficult to find a time when he would be available to do that when we're ready. And then we started that before COVID. So there was all sorts of issues about what platform we would use and would it be HIPAA compliant and all that business. But I think COVID kind of solved all those issues. So that's one way to do it. But again, you have to have a partner that's really interested in this. And I think it's sometimes difficult to find the adult providers or get them really interested in helping these patients that take more time, more of their resources, and then may not follow up or do what they want them to do anyway. I mean, we're sort of used to that with teenagers and young adults to try to convince them to do stuff. But for adult providers, they have one visit, they say, do this. And if you don't do it, that they're not going to hold your hand and talk to you about it for another 5 visits. So it's hard to find the partners. I think, the doctors at OSU and Luis were particularly interested in it actually because they wanted the young patients in their studies. And that was actually their driving force, that they want to actually get them involved in some studies to, get a cohort of patients that are not, their pancreas is not way down the line, burned out. So they wanted to get some young patients over there for research purposes. And that was their motivation to try to do that. But it's hard to find the adult providers.
So I think as a follow-up to that, the question that goes, I think, to probably any speaker, are there any legal restrictions for adult GIs performing interventions in children? So I think that's, I don't know if you want to take that, Cheryl. So it's a convention with endoscopy groups, it's becoming more limited.
Yeah, so I mean, as the question states, we used to provide rely on adult providers a lot to do our advanced endoscopy. And now we have dedicated pediatric providers. And that is not because of any change in the law. I don't think there's any law that affected it. It's just the availability of trained pediatricians. When we were relying on adult providers, well, first of all, the patient had to go over to where they were credentialed, because getting an adult provider credentialed in the pediatric hospital was a big would take a lot of effort. And they were, restrictive in who they would do. If the patient was too small or had some stuff going on that we'd have to send them to a pediatric institution. So, I think adult providers, if you have a 150-pound 10-year-old, they might, be okay. But if you're getting down to 2- and 3-year-olds, they're wise, they are not comfortable with it. So it's not been a change in the law. It's just a more training of the pediatricians, or recognition that we do have these patients that need this kind of treatment. The concern in the past was that we just didn't do it enough. They wouldn't stay up on their skills. And I think that that's completely been shown to not be the case now.
Okay.
There's a question about when to
Dr.
do.
Lo, do you want to take that one? Yeah.
There's a question about when to do total pancreatectomy that was.
Yeah.
Pointed yet.
We were going to ask you that next, so thank you for taking it.
Yeah, so it's at what point do you recommend total pancreatectomy with auto-islet cell transplant for a patient who tests positive for PRSS1 after 1 episode, after 2 episodes, mild pancreatitis or severe pancreatitis? So we don't have a good biomarker, and that unless there's something Dr. Bellin has identified recently I don't know about, for when to start to recommend a total pancreatectomy. And for the most part, it's driven by quality of life, not necessarily the number of episodes or the severity of the disease. So the things that mostly affect quality of life in kids are pain, so having lots of pain, frequent pain. And the other thing that has just triggered that has been just sometimes children are in and out of the hospital. They're in the hospital 10 out of 12 months. And their quality of life for them and the family is poor. And even though they may not have chronic changes in their pancreas that you can see, they probably do. And that's someone who I would refer for pancreatitis. So it's really driven by quality of life, in my mind. Once with PRSS1, they're also, sometimes the parent, particularly the parent who's affected, has a strong opinion on what they want to do. So it has to be a discussion with the family.
Right, and I think NAS began a position paper about role of surgical management, including a TPIAT for children with chronic pancreatitis, and that could also be a resource. Any other questions?
So, Maud, have you ever seen a child with PRSS1 mutation without any family history of pancreatitis?
Yes. That happens. That can happen.
Because also went to test. I know that sometimes you can link etiologies like Dr. Garipi was asking with chemotherapeutic agent. But I've also seen a child who had 2 viral infections induced attacks, and she ended up having PRSS1 mutation. So it just opens our eyes that, there are a lot of things that may look like the etiology may be from what we think is causing it, but it could just be hereditary. Yeah.
I mean, the issue with viral infections and their association as a cause of pancreatitis is a difficult one. Pre-COVID, kids averaged about 8 infections a year. So that have a temporal association of upper respiratory symptoms with an attack of acute pancreatitis was pretty common. Or even if you tried to do more sophisticated studies, so that you can identify what viruses the kids have been exposed to in recent times by looking at viral DNA in their bloodstream. But even that makes it, it may be true, and they had pancreatitis and they were in viral infection, but it doesn't really cause pancreatitis. I mean, there's some viruses, mumps virus we know can infect the pancreas. Adenovirus can infect the pancreas, but most patients who get those viruses don't have pancreatitis. So it's really tricky to attribute pancreatitis to a viral etiology. So that wouldn't stop me from doing genetic testing.
Thank you.
Any other questions? It doesn't look like we have any further questions to the speakers, so we may be ending early. A little ahead of time. Those were wonderful talks. So thank you, Drs. Lowe and Garepi, and my co-moderator, Dr. Decay and Dr. Bellin, and thank you, LP, etc., for coordinating, and CAPER to make this happen, and everyone who participated to this wonderful session.
Thank you to our
Thank you.
speakers and moderators, and I hope everyone's able to join us again next week, Wednesday.
Goodbye.
Thank you,
Thank you.
everyone.
Have a good
Yeah.
night.
Bye.